All right, part 2 of pathology. We're going into chest pathology first. COPD, chronic obstructive pulmonary disease, an obstruction of the normal flow of air within the lungs. Chronic bronchitis and emphysema are your two main players here. Emphysema, chronic destruction of the bronchi and alveoli. So you might see this term barrel chest. Think of those chest x-ray patients that you have to do their lateral and a crosswise almost. Their chest turns into sort of a barrel shape. Smoking is the primary risk factor, but it can be caused by pollution, but 90% of the deaths are related to smoking. So it's your number one. Atelectasis. I know you guys know this one by now, but we're going over it again. Condition where either a portion of the lung or entire lung has collapsed. Results from a bronchial obstruction. Can be caused by a tumor, foreign body, mucus plug. It usually has this linear appearance going across the lung here. So kind of horizontal, right? Pneumothorax, you guys know this one too, but air introduced into the pleural space, right? What does it look like? You don't see the lung markings, these nice striations over here. See how clear and black this is? These arrows are identifying where the lung is being crushed to. It usually causes a collapsed lung. Common cause of it is trauma. It can be spontaneous. Some young adults that are tall or have a quick growth spurt have been known to have spontaneous pneumothorax, or it can be for absolutely no reason whatsoever. And then sometimes when they're doing something called a thoracentesis, usually over in CAT scan department, or a chest tube insertion, they can actually cause a pneumothorax. It can be life-threatening depending on the size and how quickly it develops. Subcutaneous emphysema is the air escaping the patient's lungs. It's usually following a traumatic pneumothorax, and it enters the surrounding tissues. If you palpate it, it'll sound like crackling or popping noise. It's referred to as crepitation. It actually feels like popcorn. If you do ever have one of these patients and you go to touch them, it's crunchy. It feels like kind of popping popcorn. It's a little gross. All right. The air will be eventually absorbed by the body. Pleural effusion or hydrothorax would be excessive fluid in the pleural space. May require the insertion of a chest tube to drain the fluid depending on how much fluid they have going on and how it's affecting them. But so usually they use the thoracentesis method. They use a needle to drain the fluid. Which view shows your pleural effusion the best? That'd be decubitus chest, right? So air rises, fluid drops. So we always look side down on our decubitus chest. Unlike abdomen, we look side up. Chest, we're looking for fluid, so we look side down. Hemothorax, just a reminder, that's blood. Pneumothorax is blood and air. Pneumonia and empyema. Pneumonia is the infection that inflames the air sacs in one or both of the lungs. The air sacs may fill with fluid or pus, causing a cough with phlegm, fever, chills, difficulty breathing, no fun for all. Aspiration pneumonia, the patient inhaling a foreign object into the bronchial tree. Empyema is defined as a collection of pus in the pleural cavity, gram-positive or culture from the pleural fluid. It's usually associated with pneumonia, but may also develop after thoracic surgery or potentially a thoracic trauma. I always mess this one up, but pneumoconiosis. I'll have to look that one up again. I always mess that word up. Occupational disease where the dust or particulate matter is inhaled. See how you can see in the lung fields here, there's all of this matter over here. Silicosis is inhaling silicone dioxide, which is sand. So remember S for sand. Asbestos is obviously inhaling asbestos dust. And black lung would be inhaling coal dust. Bronchiectasis is an irreversible dilation of bronchi caused by bacterial infection, and it usually affects the base of the lungs. CHF, congestive heart failure, chronic progressive condition that affects the pumping power of your heart. Usually fluid builds up around the heart, causing it to pump inefficiently. Cardiomegaly, is when your heart is enlarged. Dextrocardia is when the heart points to the right side. TB, you guys know TB, tuberculosis, right? Disease, it's caused by bacteria. The bacteria usually attacks the lungs, but can damage other parts of the body. TB spreads through the air, so make sure you have your N95 mask on. Okay. All right, moving on to abdomen. Abdomen pathology. Review abdomen anatomy for me. A AAA, aortic abdominal aneurysm. It's a weakening of an arterial wall that results in a bulge or balloon-like appearance. So right here, it's kind of identifying for you the bulge right here of the AAA. Most of these patients, if they're concerned about AAA, go to CAT scan. They don't come to us. But potentially, we could pick it up on, say, like this lateral spine radiograph right here. So it can often be fatal. Average age for a AAA is 65 to 70, and a lot of times it's tricky because the patient actually has minimal to no symptoms, and it happens very quickly, and they can burst very quickly. Ascites is the accumulation of fluid within the abdomen, and many disorders caused by this. The most common is high blood pressure in the veins, and then it's pressure into the veins that bring blood to the liver, which is usually due to cirrhosis. And we'll talk about cirrhosis in a second here. Cirrhosis is a late stage of scarring of the liver caused by many forms of liver disease and conditions such as hepatitis and chronic alcoholism. I would say we see them most with this chronic alcoholism. A lot of your ER patients have that as well for cirrhosis. Bowel obstruction can be partial or complete loss of normal function of small and large intestine. There's a few types. So dynamic or paralytic ileus would be reduction or loss of peristalsis, usually caused by medications. Anesthesia tends to slow your bowel down, right? Abdominal surgery, some type of illness. Mechanical obstruction is a motility disorder that results in some type of structural abnormality. It can be caused by hernias, adhesions, volvulus, intussusception. Just a reminder, volvulus, it's a loop of intestines that have twisted around itself, causing a partial or complete obstruction, excuse me. Adenocarcinoma. So it's a type of neoplasm that starts in the glandular tissue and can be the cause of a bowel obstruction. It's commonly referred to as colorectal cancer. This red arrow here on my image is pointing to something we call the apple core sign or the napkin ring. It's really a tightened area here where the neoplasm is. This has a high mortality rate. A lot of the patients that we see for this go for a colonoscopy. They can't get through, and so they send them for a barium enema, wanting to check and make sure everything is open, and we might find this. Diverticulosis versus diverticulitis. Okay, the boards love to trick you on these two terms because they're a little bit different, right? So diverticulosis is when you form diverticula in the walls of your digestive tract. Diverticulitis, and we're going back to med term, right? Itis, infected. Okay, so losis, forming, litis, infected. A couple different types of stones. So cholelithiasis, here we've got a picture here of gallbladder, and then kidneys. This is a kidney stone here. The kidneys usually enlarged. I actually think that might be close to the ureter in that picture, and then pancreas stones, pancreolithiasis. So know these three terms for stones and where they are. All right, additive disease versus destructive disease. This is going to be on your board. So I'm going to send this chart to you guys in a handout as well. But so you need to know which is considered an additive and which is considered destructive. So an additive disease is a disease that causes the body tissues to thicken. There's an increase in atomic number, increase in density. They require an increase in technical factors. Destructive is when the disease causes the body tissues to thin. There's a decrease in everything, and then you decrease technical factors. So make yourself some flashcards for these. For abdomen, what are the additive? What are the destructive? Chest x-ray, and just think, you guys know this. Air needs less technique than fluid, right? So, you know, pleural effusion, fluid. Ascites, fluid. You guys know that, right? Pneumothorax over here, air. That needs less. So go with what you know. You guys know this. So obviously an edema, a tumor is going to be thicker. Let's go down the bottom here. So Paget's disease, I told you to make sure you know that one, right? That's going to be that kind of cotton wool appearance. It's either usually a picture of a skull or a pelvis, right? And then on the other side, we've got osteoporosis. Know that one for sure. And then you want to know the difference probably between osteopetrosis and osteoporosis, and multiple myeloma is a big one. So I really want you guys to focus on knowing your terms, knowing your terminology, definitions. Make a flashcard for every one of these if you can, and start working on those. So additive is going to be an increase in tissue thickness, increase in technical factors. Destructive, decrease in tissues, decrease technical factors. So destructive, decrease, additive, increase for me, okay? Is that my last one? And that rounds out pathology.